For dog owners, an itch is an itch is an itch. Whatever you call it, they call it upsetting, frustrating, and even hopeless as they show up at your practice looking for relief for their pets. You know that putting a name and diagnosis to the itch is a critical step if that diagnosis is atopic dermatitis. Arriving at antibody therapy just may be the revolutionary next step. Hello, I'm Sheila Hyland, and you're live with Velocity World Media, bringing you premier private programming from around the world. Welcome to Antibody Therapy, the next horizon in canine atopic dermatitis, a high-definition broadcast event sponsored by Zoetis. This is a conditional launch interactive program. You have been chosen as a part of a select group of key opinion leaders in the dermatology community to participate in the conditional launch of canine atopic dermatitis immunotherapeutic. Through this conditional launch, Zoetis looks to gain both clinical and quality of life feedback from you as well as your pet owners. This will allow Zoetis to better prepare prior to launching to the entire veterinarian community. Participation in this program will allow your clinic to order canine atopic dermatitis immunotherapeutic from Zoetis during the conditional launch. And now, joining us in studio are a panel of experts, some of the leading voices in the battle against the canine itch cycle. Dr. Candace Sousa will be moderating our discussion today. She is a veterinary dermatologist and Associate Director of Veterinary Operations for Zoetis. She owned a private dermatology referral practice in Sacramento before joining Zoetis in 2003. Steve Dunham is Associate Research Fellow, Veterinary Medicine Research and Development for Zoetis. Steve has almost 18 years of pharmaceutical experience in both antibacterial and monoclonal antibody therapeutics for human and animal health. Dr. Gina Michaels is Associate Director, Veterinary Medicine Research and Development at Zoetis. Dr. Michaels has contributed to the development of several pharmaceutical and biopharmaceutical projects and has served as the clinical lead for the anti-canine interleukin-31 monoclonal antibody program. Dr. Andy Hillier is Senior Veterinary Specialist in Dermatology for Zoetis. After his 17-year tenure as both Professor and Head of Dermatology and Otology Department at The Ohio State University, he joined Zoetis in 2013. And rounding out the panel is Farah Dewar, Marketing Manager, Dermatology for Zoetis, to discuss the specific details of this conditional license program. We'll join our panel in a moment, but first a few notes. Today's program is in two parts. Our presentations were recorded live to tape and broadcast in high definition via our interactive Jetstream platform. At the conclusion of the presentations, you will be joined live by one or more of our experts who will take your questions as they come in today and answer them live on the air. We'll be using Mindstorm, our peer-to-peer channel of communication, for our first question and answer segment. At any time during the program today, you may use the question box at the upper right-hand side of your screen to submit a question about canine atopic dermatitis immunotherapeutic. You can also text or email questions sent to CADI, C-A-D-I, at velocityworldmedia.com. Or if you prefer, you can call into our number below. At the end of the presentation, our live panelists will answer as many questions as time permits. So now let's join Dr. Candace Sousa and the panel for the start of today's program. Dr. Sousa.
Thank you, Sheila. We know that there are approximately 8.5 million dogs that suffer from pruritus that are seen by veterinarians every year. We also know that about 20% of those dogs are diagnosed with atopic dermatitis. That's about 1.3 million dogs. The diagnosis of atopic dermatitis is a diagnosis of exclusion. The first thing a veterinarian would do when seeing an itchy dog would be to rule out infectious causes of itching, such as scabies, yeast, or staph infestations. They need to also consider underlying causes for these infections that are non-allergic, such as dermatitis and hypothyroidism. And then there are rare infectious causes. But once a dog has been cleared of infections and scabies, we then think they have an allergic disease. And certainly flea allergy is the most common allergic skin disease we see in the dog. There are great products now to control fleas and prevent flea allergy, but many times owners aren't as compliant as they should be in routine use. Once fleas are under control, though, then a veterinarian can make a diagnosis of atopic dermatitis. What we know is there are three common reasons for this. The first would be a dog who's having a reaction to foods. These clinical signs mirror and mimic everything we see in classical dogs with atopic dermatitis. Most commonly, though, environmental allergens such as pollens and house dust mites are a more common cause of atopic dermatitis. And lastly, there's a group of dogs who have non-IgE mediated disease, which we call atopic-like dermatitis. And finally, there are rare allergies we see in dogs like contact allergy and drug eruptions. Unfortunately, this disease is persistent and not curable. It affects the quality of life of both the pet owner and the dog. We do have some therapies that have been used historically that work well. Corticosteroids work very well to control the itch and inflammation associated with this disease, but the side effects limit their use both in the short term and their chronic use. We also know that corticosteroids affect many other cells of the body, so they are non-targeted in their effectiveness in the dog. Unfortunately, antihistamines do not work well to control the itch associated with atopic dermatitis. Topical therapy is critically important to both remove the allergens, control the infections, and improve the barrier function of the skin. But this presents an issue for owners in time consumption and effort. And lastly, cyclosporin works very well to regulate the dysregulated immune system involved in atopic dermatitis. New research has shown that the pathophysiology of atopic dermatitis involves not just allergens, but this continuous cycle of itch and inflammation that's mediated by other molecules such as proteases, kinins, neuropeptides, and especially cytokines. These contribute to the cycle of itch and inflammation that we see in these dogs, such that the skin will eventually get chronic and thickened and perpetuate the cycle of scratching and inflammation. The cytokines we know about in atopic disease are primarily secreted from the T lymphocytes after antigen is presented from the antigen-presenting cell, the Langerhans cell. Cytokines such as interleukin 4, 13, and 31 play a critical role in activating other immune cells, contributing to the breakdown of the skin, and most importantly, stimulating neuronal itch. These cytokines act by binding to a specific receptor on a cell surface and activating the Janus kinase enzymes, which are part of the intracellular portion of these receptors. This stimulation of the JAK enzymes, particularly JAK1 and JAK3, causes the activity that cytokine wants to induce. Especially now we want to focus a little bit on interleukin 31. These interleukin 31 receptors are located on the surface of keratinocytes, immune cells, and particularly neurons. When interleukin 31 is activated, it causes the stimulation of itch in people and in mice. We know that about half of the dogs with atopic dermatitis do have an elevated level of interleukin 31 that can be identified in their serum. We also know that the injection of interleukin 31 into laboratory dogs will make them itch. Apoquel is a Janus kinase inhibitor that works to inhibit the activity of several of these cytokines involved in allergic skin disease, such as interleukin 2, 4, 13, and 31. So the question then came up, I know I can inhibit the JAK enzymes for all these cytokines, but what would happen if I could inhibit just one cytokine, such as interleukin 31? So I'd like to have Steve now tell us about the works at Zoetis in research into developing a monoclonal antibody that would target canine IL-31.
Thank you, Candace. So our research began in about 2009, and at that point we knew that IL-31 could induce itch in a variety of species, and we knew that there was an increased level of IL-31 in several human diseases such as atopic dermatitis and urticaria. What we didn't know is really what the role of IL-31 was in natural diseases for dogs with atopic dermatitis. So as we set out to do our research, our first experience was to demonstrate what happened in dogs when we administered IL-31 to them. And in this figure you can see we had 3 test articles that we looked at. We had PBS group shown in blue, T01. We had another group that was given the vehicle which is a mock protein purification of IL-31, shown in gray. And then in red, we had another group where we administered IL-31. Shown on the y-axis is the observation of pruritic events of these dogs following administration. So as you can see in this graph, clearly we are inducing pruritus when we administer IL-31 to dogs. So now that we had this established in the laboratory, we wanted to set out to ask the question, how could we stop this pruritic induction in dogs? And we knew that we wanted to have a therapeutic intervention that would have a long duration of action. So that told us that we had to have a molecule that would probably have a long half-life, and it really focused us towards a monoclonal antibody therapeutic. And monoclonal antibodies have been used in humans for a long time. There's been a lot of progression on going from a mouse monoclonal all the way to a humanized monoclonal. And we have a short video to show you that really shows how vaccinations, which were actually the very beginning of medicine, began, and how that's progressed into monoclonal antibodies, which now are really at the forefront of innovation in human health and soon animal health as well.
The therapeutic use of antibodies, building on 1,000 years of discovery in antibody science. During the early part of the second millennium in China, dried scabs were removed from a smallpox-infected patient and put into another uninfected person, creating a mild, protective infection known as variolation. Fast forward to the 1760s, where it was observed that dairy workers did not contract smallpox because of their previous infection by the cowpox virus, a similar pathogen. Using this knowledge, Edward Jenner, an English physician, inoculated a boy with pus from a cowpox blister. Later, when the boy became infected with smallpox, he did not become ill. In 1879, Louis Pasteur had already made a series of important discoveries in the fields of pasteurization and vaccination when he produced the first laboratory-developed vaccine, a vaccine for chicken cholera. More than a decade later, in 1890, two scientists, Shibasaburo Kitasato of Japan and Emil von Behring of Germany, contributed to the development of the diphtheria antitoxin. They showed that they could cure diphtheria in pigs by injecting them with the blood of an immunized animal. In the 1920s, Michael Heidelberger and Oswald Avery identified that proteins are the building blocks of antibodies. In the 1940s, Linus Pauling confirmed the exquisite specificity of antibodies by proving that the lock and key binding mechanism is dependent upon shape rather than the chemical composition of the antibody and antigen. This theory was set forth in the 1890s by scientist Paul Ehrlich. These discoveries led the way in 1975 for the first monoclonal antibodies to be developed in the laboratory. The technique uses hybrid cell lines grown in culture to produce single specificity monoclonal antibodies. Cesar Milstein and Georges Kohler jointly received the 1984 Nobel Prize in Medicine and Physiology for the hybridoma technique of producing antibodies with single specificity. Through the 1990s, antibody engineering allowed for molecular modifications that enhance the therapeutic potential of antibodies, such as a longer half-life, tighter binding, and decreased immunogenicity risks. Into the new millennium, new technologies are used for discovering antibodies for human therapy. Scientists can now produce antibodies that neutralize disease-causing proteins in multiple therapeutic areas. And now, antibody therapies are being developed for various therapeutic applications in veterinary medicine.
So as you can see in the video, vaccinations have been a very key route for therapeutic interventions. And usually when we vaccinate a person, you generate antibodies in that person or in that dog. Those antibodies bind your bacteria or virus if they're against a microorganism. And then those antibodies are used to either stop the virus from entering a cell, or they actually kill the bacteria through antibody-dependent cytotoxicity or clearance. When we talk about antibodies as therapeutics for IL-31, it's really a different application. As you see in panel C, I was referring to you're actually targeting cells and you're tagging them with an antibody that you would like to remove. For IL-31, this is a soluble cytokine. It's circulating in the body, and what we'd like to do is basically bind it with an antibody and prevent it from being able to activate its receptor. So it's somewhat similar to mopping up any IL-31 that's in the tissues and serum so it cannot have its pro-inflammatory effect.
How did you go about then making these monoclonal antibodies?
Let's just start out with the description on how they're made and at least describe how we made our anti-canine IL-31 antibody. We have a lot of ways to do this, but in this particular instance, we started by a traditional technique called hybridomas. The way this works is we'll take a mouse, we'll immunize it with canine IL-31, and that mouse will generate antibodies that recognize the canine IL-31 protein. We'll then identify the cells that are producing those antibodies one at a time, and we can characterize each of those antibodies and make sure they possess the necessary characteristics that we need to turn them into a therapeutic. And by this I mean we make sure they bind IL-31 very tightly, and we make sure that when they bind IL-31, that binding prevents IL-31 from being able to bind its receptor and trigger downstream signaling through the Janus kinases. Once we've identified our favorite mAbs and candidates that could become therapeutics, we like to do a process that we call speciation, which is basically taking these mouse monoclonal antibodies and converting them into a canine antibody or a caninized antibody. And the purpose of this is because we know through all the human health efforts that when you administer a non-self protein or a mouse antibody into a human or a dog, that you will elicit a response where that dog will now recognize this mouse antibody as not native protein. And this antibody response can actually result in inhibiting the ability of our therapeutic antibody to bind IL-31, therefore resulting in a decrease in efficacy. So we really want to design an antibody that is silent to the immune system and is not recognized so we can have the longest duration product we have. And I guess to illustrate this a little bit more clearly, I'd like to look through this next slide, which shows in red we have a mouse antibody, and this is 100% mouse sequence. If we were to inject this into a dog, we would get a rapid immune response and it would become non-efficacious in about 7 to 14 days. So what we do is we take the binding region of that mouse antibody and we put it on a canine backbone, as shown here. Now this antibody still is about 35–37% mouse sequence, and it still has potential to become immunogenic. So we even go further and we identify the residues we know that are specifically responsible for binding IL-31. We'll take those individual residues and paste them on a fully canine backbone. The result of these efforts are that we have an antibody that is over 90% canine sequence. It's over 90% identical to antibodies that are circulating in dogs right now. And really the advantage of that is that we're minimizing any risk for immunogenicity. We don't want the dog's immune system to recognize our antibody as a foreign protein and then reduce its efficacy. So through this process, the goal is to really generate an immune-silent antibody that can still bind IL-31 and stop any of its activity. The other key characteristic of monoclonals, and particularly for anti-IL-31 monoclonals, is that we don't feel that there's a huge safety risk due to the mechanism of IL-31. We had a lot of safety data based on the Apoquel project, where we knew we can administer Apoquel for long term, and we can see we don't see any safety issues at all, and because Apoquel is targeting several cytokines, we have confidence in safety that removing IL-31 alone should be at least as safe as Apoquel. The other component about IL-31 is we don't see any evidence that it's involved in normal homeostasis of the immune system. The only time we see that it matters is during a pro-inflammatory response. So we feel like it's a cytokine that marks bad conditions that we want to basically inhibit that from happening, such as atopic dermatitis. And lastly, antibodies are catabolized through normal protein process. So it's not like a small molecule where you could get liver toxicities. It's a protein that gets broken down into amino acids, and these amino acids can just be fed right back and used to generate more protein. So we think there's really minimal mechanistic safety risk with this product, and also as far as the catabolism of the antibody itself.
Well, that answers my questions. Thank you very much. So I'd like to now turn to Dr. Michaels so that Gina can explain to us what we learned in our clinical field trials using this monoclonal antibody.
Well, Candace, we actually conducted 2 randomized, double-blind, placebo-controlled clinical trials in client-owned dogs with atopic dermatitis. The first study was an efficacy study. To be eligible, dogs had to have at least a 1-year history of chronic, non-seasonal atopic dermatitis and have undergone a diagnostic regimen sufficient to eliminate from consideration other typical rule-outs for atopic dermatitis. All dogs were withdrawn from any medications that could confound efficacy assessments, like corticosteroids, Apoquel, or cyclosporin. I'll tell you a little bit more about the study as we look at the results. After dogs were enrolled, they were dosed once on day 0 with a single subcutaneous injection of either placebo or Canine atopic dermatitis immunotherapeutic at a dose of 2 milligrams per kilogram, indicated here as ZTS 00103-289. Owners assessed their dog's level of pruritus on day 0 prior to treatment and periodically throughout the study using a 100 millimeter pruritus visual analog scale score. This graph shows a summary of the percentage of dogs that achieved treatment success based on the owner assessment of pruritus VAS score. The y-axis represents the percentage of dogs that achieved treatment success, and the x-axis represents the time in days that the dog was on study. The asterisks indicate a statistically significant difference compared to placebo. And as you can see, already by day 1, significantly more dogs in the monoclonal antibody treated group achieved treatment success. And by day 3, over 80% of the dogs achieved treatment success, with this level of efficacy maintained through day 21. By day 28, the level of treatment success declined slightly to about 70%, indicating this may be a good time to give a second dose if needed. But as you can see looking at the data, significantly more dogs achieved treatment success after a single dose of the monoclonal antibody from day 1 and at every time point thereafter through day 56. Let's look at the efficacy for pruritus a different way on the next graph. This slide shows a graphical summary of the average owner-assessed pruritus scores. The y-axis represents the owner pruritus visual analog scale score. The x-axis represents the time in days. And once again, you can see that already by day 1, there is a significant improvement in the average pruritus visual analog scale scores as assessed by the owner. Now the owners, when they assessed the scores on day 0 and throughout the study, used the 100 millimeter visual analog scale score, and a schematic representation of that scale is shown on the right of the graph. And you can see the severity levels distributed across that scale. On day 0, the average score in both treatment groups was about 70, which corresponds to a severity level of severe. So on average, the dogs started out with severe pruritus. Already by day 1 in the treated group, the average pruritus scores improved to mild, and from day 1 through day 49, the average scores improved from mild to very mild. So Candace, we were really impressed at how well blocking IL-31 alone was effective in reducing pruritus in dogs with atopic dermatitis. But what about the skin condition scores? Could blocking a single cytokine, interleukin-31, significantly and substantially impact skin condition? Let's take a look at the results. This slide shows a graphical summary of the percentage of dogs that achieved treatment success based on the investigator assessment of the skin condition. At day 0 prior to treatment and periodically throughout the study, the investigators assessed the dog's skin condition using the CADESI 03 scale. This slide shows a graphical summary of the percentage of dogs that achieved treatment success. Here, treatment success required at least a 50% improvement in the CADESI 03 score. By day 14, we're already seeing a significant improvement in the dog's skin condition based on the CADESI 3 score. And this significant difference was maintained at every time point thereafter through the end of the 56-day study, with the highest level of treatment success achieved by day 42. Let's look at skin condition results another way. This slide shows a graphical summary of the average skin condition scores at each time point. So as you can see, on day 0, the average CADESI score in the monoclonal antibody treated group was about 163, and it was about 145 in the placebo treated group, which is pretty similar. And already by day 7, we see significant and substantial improvement in the skin condition in the monoclonal antibody treated group. And we continued to have significant improvement in the skin condition at every time point thereafter throughout the 56-day study. As with any field study, we always collect safety information. So we also collected safety information in this study. The eligibility criteria for this study were quite different than the efficacy study. So in this next field safety study, for which I'm going to show you results, dogs could have already been well controlled on their current medications. They didn't have to be withdrawn from any medications, so they could continue to be treated with corticosteroids, Apoquel, cyclosporin, or whatever they happen to be on, if anything. There were also minimal restrictions on concurrent conditions and no restrictions on age, so dogs of any age could enroll. Well, let's take a look at the results for the field safety study. This slide shows a summary of the most common abnormal health events that occurred in either treatment group. And as you can see, looking down the list, the percentage of adverse events in each group is very, very similar, with the exception that there were fewer dogs in the canine atopic dermatitis immunotherapeutic group that had pruritus, and possibly a little bit fewer dogs that experienced alopecia. In addition to this field safety study, we also conducted a laboratory safety study in dogs, where dogs were treated with 7 consecutive monthly doses of either placebo or canine atopic dermatitis immunotherapeutic at a dose of 3.3 milligrams per kilogram or 10 milligrams per kilogram. And the results of that study showed no treatment-related adverse effects. So with all of the information we've gathered, that allowed us to develop a product profile. The label claim is aids in the reduction of clinical signs associated with canine atopic dermatitis. The minimum dose is 2 milligrams per kilogram, and it can be administered as often as once monthly. It comes in 4 different concentrations, 10, 20, 30, and 40 milligrams per milliliter. The vials are single use, and the entire contents should be used when first opened because there's no preservative. Let's take a look at a short video clip that shows the mechanism of action of canine atopic dermatitis immunotherapeutic.
Interleukin-31 is released upon antigen presentation to the lymphocyte. Interleukin-31 is a pruritigenic cytokine that plays a key role in the itch-scratch cycle in atopic dogs. Interleukin-31 is released from T cells and binds to specific receptors on neuronal cell surfaces, which causes the activation of intracellular enzymes. This process triggers the generation of a nerve signal that travels to the brain and ultimately leads to the perception of itch, which results in pruritic behaviors. As part of normal response to disease, plasma cells produce antibodies to block the activity of different antigens. Using the same principles, antibodies can now be administered by injection and used therapeutically in dogs. Monoclonal antibody therapy mimics the natural response to disease by providing highly selective antibodies that specifically target and neutralize only the molecules that are involved in the disease process. The Canine atopic dermatitis immunotherapeutic is an anti-interleukin 31 monoclonal antibody therapy that is designed with a high specificity profile for canine cytokine interleukin 31, allowing veterinarians to target and neutralize a key mediator responsible for the development of pruritus in atopic disease without negative side effects. The anti-interleukin 31 monoclonal antibody therapy provides sustained relief and control of the itch and inflammation associated with atopic dermatitis, regardless of a dog's age, concomitant medications, or comorbidities. With monthly injections, veterinarians restore the quality of life to atopic dogs long-term and build a stronger ongoing relationship with their owners.
Gina, thanks so much for that valuable information. In April, we had a chance to catch up with Dr. Tom Lewis. Dr. Lewis is a veterinary dermatologist who practices in Phoenix, Arizona. He's had years of experience treating some of the most challenging cases of atopic dermatitis in dogs. Dr. Lewis was one of the investigators who participated in the clinical trials. Let's go to Tom.
Well, thank you, Candace. I very much enjoyed the time with you today, and I very much look forward to using this product as a clinician and doing whatever it is I can to help this product become available for our patients.
I had the opportunity to ask Tom, how commonly do owners complain of pruritus in the dogs that are presented to him?
You know, well over 80% of the patients that present to Dermatology for Animals have pruritus as one of their complaints.
I then asked him about the percentage of these itchy dogs that he would diagnose with atopic dermatitis.
Candace, when I was a resident, 75% of my patients were diagnosed with atopic dermatitis. It was so common, I actually thought maybe I was misdiagnosing. I worried that maybe I was in a rut. So I talked with my resident colleagues. 75% of their patients were suffering from atopic dermatitis. 25 years later, when I reviewed the case logs of our residents, 75% of their patients are being diagnosed with atopic dermatitis.
We talked a bit about the challenges that veterinarians face in making a diagnosis of atopic dermatitis.
I think it depends. For the dog who shows up every March, same time of the year with the complaint of pruritus, I think the diagnosis of atopy is easy for that individual. But for the dog who itches most of the year or all of the year, I think the diagnosis is more challenging to a veterinarian. They're challenged by knowing how much of it could be atopic dermatitis, how much could be food-related, how much could be parasite-related, and complicated by infections.
I asked Tom, as a veterinarian, how do you feel about monoclonal antibody therapy?
I feel it's going to give us a new option with fewer side effects. These are areas that are getting a lot of research in both human medicine and veterinary medicine. And I think we're going to have options in the future to treat diseases more specifically with fewer adverse events.
I also wondered what he thought when he first saw a description of the product profile.
I had mixed emotions. On one hand, I was guardedly optimistic that it really would be as good as advertised. But on the other hand, I was a little bit skeptical to think that we would have a product that we could give monthly that would have the same efficacy or perhaps even better efficacy than long-acting corticosteroid injections without all the negative side effects that we see with the steroids was an exciting thing to me.
I asked Tom, how did you select which dogs should be treated with the canine atopic dermatitis immunotherapeutic and enrolled in this clinical trial?
We had a broad spectrum of patients that elected to participate in these clinical trials. On one hand, we had patients that were relatively new to us at our clinic, but they had been diagnosed with atopy and had suffered with their disease for over a year's time. Some of those patients enrolled in the clinical trial even though they were relatively new to us and new with respect to the management of their disease. We had other patients that we had been treating for several years with the conventional therapies of immunotherapy, steroids, cyclosporin, and we were having some success, but we just weren't having complete success. We wanted more. So some of those patients enrolled in these clinical trials. A third subset of patients that enrolled in these studies were some of the really challenging patients who we were failing to make a difference in their quality of life. Our conventional therapies were failing to provide adequate control of their disease. Some of those also then elected to enroll in this clinical trial. That was probably the easiest subset of patients, or the subset of patients that was most eager to enroll.
And I asked Tom that even though he was masked as to which dogs received the active product, what were his first impressions as to how dogs would respond to this therapy?
You know, as a dog owner, when you've watched your dog scratch every day for years, and then the day after receiving an injection, he's no longer itchy, that was not very challenging to know if that particular individual received the drug. As a dermatologist, I had patients that I had tried to manage and had been managing for several years, and they were coming back for their recheck 2 weeks and 1 week after the injection, and they were better for the first time during the time that I had managed them. There was no question those were not dogs receiving placebo, that they were receiving the real drug.
I want to thank my friend Dr. Tom Lewis and his dog Ruby for inviting us into their clinic for the day to discuss the canine atopic dermatitis immunotherapeutic. Now I want to turn to a fellow dermatologist, Dr. Andy Hillier. Andy, would you tell us please what your impressions are about this product and what it will hold for veterinarians?
Well, Candice, as we've mentioned, atopic dermatitis is a very common disease, and it's diagnosed every day in veterinary practices. And it's a challenging disease because we can't cure it, and there's some cases that are really difficult to treat. Candice outlined a variety of treatment options that we have at this time, but in fact, few of them have documented efficacy. There's an aspect of the treatment of atopic dermatitis that we fail to discuss and address, and that is that it's a difficult disease to continue and sustain treatment long term, which is naturally important in a chronic disease like this. So I think that the unique therapeutic profile of this monoclonal antibody, where it's an injectable that's administered once monthly, it has rapid effect, there's sustained a reduction in the clinical signs for a month, and we can continue to use it long-term if we want to, is going to be a very attractive option for a lot of owners of dogs with atopic dermatitis. And it's a wonderful addition for veterinarians in their choices that they now have to address this disease.
So how would you see this product fitting into a clinical practice? How would a veterinarian consider using this?
So let's consider the label indications for canine atopic dermatitis immunotherapeutic, which is that it's an aid in the reduction of the clinical signs of atopic dermatitis. And it joins Apoquel, which we launched last year, as a new treatment option that's highly effective for atopic dermatitis. And I want to consider both of these treatments and how they may be used appropriately in clinical practice. So if there is a need for immediate and rapid control of itch in dogs that have a flare of their allergic disease, we have Apoquel, which is a daily oral Janus kinase inhibitor that can be used in dogs that are at least 12 months of age and can be used for flares of itch in dogs that have any form of allergy, including flea allergy, food allergy, atopic dermatitis, or contact allergy. So it's particularly useful for those flares of disease and also for veterinarians who need control of pruritus during a workup of an allergic or itchy patient. And this is really important to get owners to buy in and accept an offer of a workup, because the process of a diagnostic and therapeutic trials continues for a number of months in most cases. And we need to be able to meet the expectations of owners that we can control the itch of their dog during this process, as well as to maintain compliance during protracted therapeutic trials like food trials. And so Apoquel is really effective in this manner. And of course, making a specific diagnosis is important as a veterinarian, because it's only with a specific diagnosis that you can offer specific treatments. And so, for example, let's just consider in this instance that we've diagnosed atopic dermatitis. And whilst we can continue to use Apoquel to treat atopic dermatitis long-term if we like to, There's also the option that in some dogs, they have extended duration of seasonal disease or they have year-round disease, and using oral medications for a long term may be a little challenging. Now we can offer them the monoclonal antibody therapy, which, because it's a monthly injectable and that it's highly specific and targeted and for the treatment of atopic dermatitis, really increases the options that the veterinarian has. And so, because it's a monthly injectable, I think it would be pretty obvious to most people that if there are any problems whatsoever with oral medications, such as difficulty administering oral medications to the patient, or the owner has difficulty remembering to give oral medications for many months and protracted period of time, or if there are any side effects from the oral medications, or maybe they're not just working so well. In all of those circumstances, the monoclonal antibody will be a fantastic option for those owners to consider. But I think that even owners who don't have any problems giving oral medications are going to be attracted to the worry-free reliability of a once-a-month injectable that works rapidly and is effective for an entire month and can be continued long-term. And so that's really important in terms of sustaining effective treatment for a disease like this that has such chronicity.
Well, with the option of 2 therapies now to treat atopic dermatitis, how are they different?
So we recognize clearly now from all the information that we have that there are distinct similarities. They're both safe treatments, they both work rapidly, and they're both highly effective. But there are some distinct differences that we need to recognize. Firstly, Apoquel blocks the phosphorylation site of the Janus kinase enzymes on the intracellular portion of the receptors after the cytokines have bound to their receptor. This prevents downstream signaling and activation of allergic functions of the target cells. In contrast, the canine atopic dermatitis immunotherapeutic acts extracellularly by binding to interleukin-31 before it binds to the receptor. In addition, Apoquel has effects on the function of several pro-allergic cytokines, the Th2-derived cytokines interleukin-2, 4, 6, 13, and 31, whilst the monoclonal antibody affects only the one cytokine, that's interleukin-31, that which is important in neuronal itch. Additionally, we should recognize some clinical differences. Apoquel is designed to be used in dogs that have allergic dermatitis that may be flea or food or atopic or contact allergy, whereas the monoclonal antibody is specifically for dogs with atopic dermatitis. Secondly, of course, Apoquel is administered daily and it's an oral medication, whereas the monoclonal antibody is a monthly injectable. And finally, Apoquel can only be administered to dogs of 12 months of age, whereas the monoclonal antibody can be used in dogs of any age.
Thank you so much, Dr. Hillier. And I want to thank all of the members of the panel and to Dr. Lewis in his practice in Phoenix for helping you to learn about the canine atopic dermatitis immunotherapeutic and monoclonal antibody therapy. I also want to thank you, the audience, for taking time out of your day to learn about this conditional license program.